Hello, medical coders. This is Janet Thompson. I did get to review your all's feedback for check-in survey 3, and I have some information I was going to share to you pertaining to that will hopefully help. So modifiers was a big topic, and I knew that was coming. So some items I'm going to discuss with modifiers. The only familiarity we get with this comes from practice. There's no index to look up these modifiers like we have when we look up our ICD-10 or CPT codes. Every payer or insurance company can be different as to what kind of modifiers they will accept. Medicare sets the standard for a lot of insurers, but that is something to consider. There's several ways to go about doing these modifiers, and we're just going to get knowledge of this through practice. So I wouldn't stress about this, knowing when to apply modifiers, when it's correct, when it's not correct. We're definitely going to be practicing on this. Another thing to keep in mind is modifiers will either increase or reduce reimbursement of services. So that's why they are added. There are lots of instances where certain CPT codes cannot be billed together due to the National Correct Coding Initiatives. Edits, they call them, and we learn about this in medical insurance class. We download the spreadsheet and where we can compare CPT codes, and it shows what codes are allowed to be billed together and which ones are not, and sometimes that rule can be bypassed with a modifier. So that's another example. HCPCS Levels 2 modifiers are mandated by Medicare, so not every payer accepts these. There is a cheat sheet on the back cover of the first page of the CPT book that has the most common HCPCS modifiers that you'll be using. But the thing to keep in mind is we will get lots of practice before we get good at these, and every situation can be different. So these are the HCPCS Level 2 modifiers on the back of my book. Now, it very well could be possible your CPT book doesn't have this. I'm not going to assume anything, but these are searchable online as well. But that's nice that we have that on the back of our very front cover of the CPT book, these commonly used modifiers. So you'll see there are a lot of direction. We have left side versus right side, upper eyelids, lower eyelids, specific fingers and toes. And then in Appendix A of the CPT book, this is where the CPT modifiers are at. So this is where we can go to review their descriptions. And like I said, there's not an index that lets you look these up specific by scenario. We just get it from practice. Physical status modifiers only apply to anesthesia codes, and specific to the anesthesia codes listed in the very first section of our book. It's a smaller section of the book, but that's what these codes apply to. They do not apply to any other CPT codes. This is usually going to be captured by an anesthesiologist. So the physical status modifiers ranges from one level from a healthy, normal person up into patients with extreme systemic illnesses like progressed cancers or brain dead individuals that are having organs harvested. So there's only 1 through 6 of the physical status modifiers, and again, these only apply to anesthesia codes, and we're not going to be doing much more applying than a P1. You're not going to have to guess what is the physical status that a person is in, rather. Other common modifiers we've been looking at in class up to now is modifiers 26, 50, and 52. And all of these are in Appendix A. Common HCPCS modifiers we discussed includes left and right. Let's look at modifier 26, professional component. We talked about this with radiology and pathology. This is for a physician's time and skill to interpret results. So it's not a bill for the technical component that went into getting those results to make it happen, like somebody running a radiology machine, putting film in it, a technician that's trained to run it. This is the professional services of a doctor rendering his or her opinion on results. So the doctor did take the item, they didn't produce that picture themselves or that film, but they're reading it and giving an opinion. So example 70190-26. So this code is for a radiological exam of the optic foramina professional component only. So what this means is the doctor billing for this code, all they did was read and give an opinion. They didn't take the film. So a radiology code in general has built into its reimbursement the technical and professional component. Now, sometimes radiology codes may specify professional component only or supervision interpretation. So that means you don't need that modifier 26. But as a general rule, the radiology codes contain both components. So if I'm a technician, I want to reimburse for my time and services going into making that exam or film, I can bill 70190-TC. The TC is a technical component modifier, which I didn't list that here, but it was over in our previous chapter. So we'll see modifier 26 pop up quite a bit. Modifier 50 versus right or left. So 50 is a really common modifier. That's easy. We like that one. It's lateral procedure. And left and right are HCPCS levels 2 modifiers for Medicare. So again, not every insurance accepts these. So you don't default by just adding the modifiers, which is where the confusion is going to come from. But some examples, we have 27130, total hip replacement. That's either bilateral, left hip, or right hip. So you can see as an insurance why you would want to know or have it specified the laterality or which side. Modifier 52, we covered this recently with radiological services. It can apply to other areas as well, but 52 reduced services. So under certain circumstances, a procedure is partially reduced. So like I mentioned earlier, modifiers will either increase or decrease a procedure's monetary reimbursement. So this is going to be a reduction. And example 70220-52, this was a radiological exam of sinuses, complete minimum of 3 views performed. And let's say I only performed 2 views or 1 for whatever reason. Then I append that modifier and then I'm correctly reimbursed. Otherwise, I'd be getting more reimbursement that I didn't necessarily earn. Indented CPT codes. This was a good item that was brought up that we could use some practice with. So I've got some examples from the CPT book, starting with code 59320. When you read the CPT code, you read up to the semicolon. That's what I've got highlighted up here. Read up to the semicolon. So code 59320, circlage of the cervix during pregnancy. There's our semicolon, vaginal. Code 59235, circlage of the cervix during pregnancy, abdominal. So that's how that code actually reads. It's indented, so it's a part of 59320. That's its parent code. Let's look at another example. This is from female reproductive system. So 59120, surgical treatment of ectopic pregnancy. There's our semicolon. Tubal or ovarian, requiring salpingectomy and or oophorectomy. These are great medical terms. So salpingectomy is removal of fallopian tubes. Oophorectomy is removal of the ovaries. Abdominal or vaginal approach. And 59130 will read surgical treatment of ectopic pregnancy, abdominal pregnancy. And you can see there's several other codes listed under there, 59135, 36, and 40. So these are all indented or a part of that parent code 59120. So again, you read up to the semicolon. All right, just some general review on looking up CPT codes. We have an index, so that makes it handy. So it's just like using our ICD-10 book, except we look up by names of procedures. Whereas with ICD-10, we are the diagnosis, the ailment, what's making you sick, what's wrong. Here we are focusing on procedures, so we might look up arthroplasty, cardiac catheterization, acupuncture, anesthesia, cholecystectomy, which is a good medical term. It's removal of the gallbladder. You can also find procedures under an entry for anatomy, like if you look up abdomen, chin, or femur. And you can also turn and review book sections. Sometimes it's easier to code that way, especially for evaluation and management services. I never use the index for those. But you can turn to just the section of the book, like the surgery section of CPT with integumentary system or musculoskeletal. They have similar procedures. So there's a excision column, introduction or injections column, incision column, and it's based on the anatomy. But that's getting a little more advanced. We go over that in advanced coding class. So for now, your best bet is to work with the CPT index, looking at the names of the procedures or the anatomies. There was a question on when to use E-codes. So we don't have to focus a whole lot on these. This is going to be if you work in orthopedics, maybe if you work in the ER, workers' comp. This is where you're going to get into more of the E-codes. And we have 4 different categories. So it's the cause of injury, place of occurrence, activity during the occurrence, and the patient status. Were they on the job? That's a different type of insurance involvement. Were they at work? That's another type of insurance involvement. Were they in a public place? Were they at a school? So that's why this information is important. And the E-codes do have their own index in the ICD-10 book. So you can look up for entries, cause of injury, that's an entry in the index, place of occurrence, activities, patient status, accident, that's a big entry in that index. But you can also search for these online, and that's my preferred method. So I'm just going to pop up here and open a Google tab. And I'm going to type in trampled by elephant ICD-10. And this is I love this tool. So this gives me a code W55.89 and other contact with mammals. So that pretty well explains that. That would be kind of hard to find in the index. So this is an instance where I like to use this website. But as far as what you need to know with E-codes or to use them is whenever you're looking in your documentation and it specifically states patient was injured in a fight at a bar, they were stabbed, patient was in a parade route and fell and twisted their ankle. So you're going to be looking in the medical record for these details because a twisted ankle doesn't happen by itself, or an external injury, a stab wound, or somebody getting into a fist fight. These injuries need another type of explanation. This is why they got there. Leveling of E&M services. Again, this is a very complex structure to get your head wrapped around. There's a lot to an E&M service or evaluation and management. You'll hear us refer to this as E&M. This is probably the most important code section that you could be familiar with because most practices are going to bill for office time or physician's time. So there is a section at the very beginning of the book for E&M. You can start with the table of contents. That's what we did in our E&M review lecture in class. You need to know the location of the service. Was it at home? Was it at the office? Was it at the emergency room? Was it a consultation? Is it a preventive medicine visit? Is it a nursing home? Is it the doctor visiting a patient that's in the hospital? So you need to know the location of the service and whether the patient is new or established. And a new patient is somebody who hasn't been seen by a specialty within the last 3 years. You need to know how to find the level of care documented in the medical record. And then also keep in mind preventive medicine visits are based on the age of the patient and whether they're new or established. So your preventive medicine codes are like the easiest to get. So I like that. It's really hard. It's one thing to figure out the level of code. It's another thing when you're looking through these records, auditing them, trying to find what the appropriate level of service is. It takes a lot of time and skill. And there are a lot of jobs just for doing that. Clinical documentation improvement officers or individuals that work on the medical record. They teach clinical staff on what to document. A lot of times coders will work in this specific area and they do a lot of education. Like my friend Nikki Copley that works at King's Daughters, this is a lot of what she does. And what we're going to do is look at a few examples on how to find the correct level or code visit. So our first scenario is patient seen in ER. The visit is documented as a detailed history and exam and high decision making of the medical decision making. All right, patient seen in the ER. So we would get in our CPT book, open up the E&M section, turn to the ER codes, And we might need our table to level the E&M if needed. This is what it looks like. I think this was in the chapter 27, 28, 29 folder. We did our review. But I just marked this out here. History and exam is detailed. We had a high level of medical decision making. So what we're going to do is go to emergency department codes in the E&M book. This starts at code 99281. If you want to look this up in the book, I usually recommend starting at the back of the code range, working back, so starting at 99285, because I want to try to get the highest level of visit, because 99285 is reimbursed differently than 99281. It gets a lot more reimbursement. So our scenario, we had medical decision making was high. There was a detailed history and exam. So looking at 99285, we don't have a comprehensive history or exam. We have a high medical decision making, but we don't have the history and exam to support that code. Now, if we back up to code 99284, which I'm going to zoom in on here, we have a need for a detailed history, detailed exam, and moderate medical decision making. Well, going back to our scenario, we have the detailed history and exam, and we have a high, down here is the medical decision making, a high level of medical decision making. So we meet all three of these. Our medical decision making actually exceeds 99284, but that's okay. We can't go to 99285. We don't have enough history or exam to justify that service and reimbursement level. So this scenario would be code 99284 based on that level in the medical record. All right, moving on, we're going to look at a new patient presents to the office with comprehensive history, detailed exam, and low medical decision making. So patient is new to office, so we would start in the office codes. They're new patient. And looking at their table of service, they have a comprehensive history and a detailed exam. I think that was right. Comprehensive history, detailed exam, and low medical decision making. Whoops. So, comprehensive history, detailed exam, low. So we're on all three. We're across the board here. So, new patient office visit. This is going to be code 99201 to 99205. And we need to find a visit that has a level for comprehensive history, detailed exam, and low medical decision making. Well, looking at 99205 here, we have a comprehensive history, but we don't have an exam or high medical decision making. 99204, we have a comprehensive history. We don't have a comprehensive exam. We don't have moderate medical decision making. Coming into 99203, we have a detailed history, detailed exam, and medical decision making is low. And that is going to match what we have in our record. So even though our history is comprehensive, we don't have a medical decision making that supports, or an exam that supports 99204. So 99203, we meet or exceed. So our history is comprehensive, so it exceeds that detailed, but we don't have the high medical decision making, so we can't code any higher. So 99203 is our correct code for this scenario. So that one was a pretty hard one. You're not really going to see this level of variance being documented, but these are just for examples. Okay. Patient returns to office with expanded problem-focused history, detailed exam, and moderate decision making. The patient returns to office, so they're established. And these are the things to look out for on these type of questions. They love to throw in, I haven't seen the patient in the past 2 years. Well, they're still an established patient as long as they've been seen in a 3-year time frame. But we know this patient returns to office. We know their levels. So they have expanded problem-focused history, detailed, and moderate medical decision making. So they're going to start with the established office visit codes. They start at 99215, and we can work our way back. And if we look at the code description, these established patient codes, it's going to say they only require 2 of the 3 key components. Let me get my shape here. So I can highlight this. Okay, get out the outline. Okay, so right there it says on the code description, 2 of the 3 key components. And it's different. For an established patient, you're not going to have to do the same amount of time collecting an extensive history. So that makes sense. So you want to pay attention to that code description and what the key components are, because for new patients, all 3 of them have to be met. But here for 99214, we only have to have 2. So we need to look up for expanded problem-focused history, detailed exam, moderate medical decision making. So start with code 99215 and work your way backwards. We don't have a comprehensive history or exam, so we can rule that one out. 99214, we do have a detailed history and moderate medical decision making. So we do meet 2 of these 3 key components. 99213 is a little lower of a service than what we provided, so we want to be sure to get the full reimbursement of our work. And that is going to be code 99214. So it has the correct level of history, exam, and medical decision making, which our history we can be a little flexible on because we only need 2 of the 3 key components. So that leaves us with 99214. And then the very last thing I was going to touch on in this review is code linkage on claims. So I've talked about this pretty frequently already, so it wouldn't hurt to do another extra review. But this is a scenario, December 15th, 2019. We have a visit for a new patient, and I put in the level of the medical record. Patient was treated for oromandibular dystonia. So our office visit code is 99202. Our diagnosis is G24.2. So this is mimicking what you're going to see on your exam but this is how we fill out the service line information on the claim form. We've got our diagnosis code up here in letter A. Our office code was on December 15th, 2019, so we put our dates in. Our place of service code right here is 11, so that means office. These are available online for free. All you have to do is type in place of service codes. You're going to get the page from CMS. We have our office visit code listed there, and our pointer is linking this procedure, this office visit, to this diagnosis, and we have 1 unit of that. So this is specifically what I want you to fill out on the exam: the diagnosis, the dates of the service, the place of service code, the HCPCS codes, the diagnosis pointer, and the days or units. You're not going to be putting any modifiers in. So basically how it looks on this page is how all you need to fill out. That's all you need to worry about. And this is it for the review. And I do have a bonus point activity. So if you watch this review, if you want to answer these questions, you can submit this to me by email up until December 9th, and it's worth 10 bonus points. So your first question, write out a CPT code you can use with modifier 26. You can't use the codes that I listed in the video. I do recommend reviewing the radiology section. What area in the CPT book can you find the CPT modifiers, which is in our presentation? Write out the complete code description for 50236. It's a part of an indented code. Write the correct E&M code for a new patient office visit with a record that's a comprehensive history, detailed exam, and high medical decision making. Type your code out there. I've got the table if you need to use that for your examination. And then the last one is a code linkage question. We have a date of service on December 15th. I'm going to have you figure out what is the E&M visit, what is the E&M code for the procedure, established patient office visit, and the diagnosis was migraine with aura intractable without status migrainosis. And you will click in these boxes to type your information. I would type in the darker gray boxes here. And that's it. That's everything. So thank you for your feedback. I hope you have a good Thanksgiving holiday. And our last class session is coming up in December. So if you have any questions for me in the meantime, feel free to let me know. Otherwise, that is it for this review.